The Center for the Improvement of Human Functioning International presents this luncheon lecture. Today's topic, Overdosed America. Your presenter, Donald R. Davis, Ph.D.
Thank you. Thank you kindly. I've been a consultant to the Center for many years. I'm a nutrition researcher at the University of Texas, and the cold north wind that came through here a few days ago was just hitting as I left Wednesday morning. We were still in the 60s, so it was much colder when I got up here. I'm really pleased to see so many people here interested in this subject, something that interests me very much. And this book that I'm going to be talking about today, Overdosed America, is a really interesting book that I'm really glad I got a chance to study. And what I'm wanting to do today is just to give you a little brief idea of what's in the book and how you can get more information along the lines of what's in the book. These are photographs of the hardback and the paperback copy of the book. It came out in 2004, 2005. I'd like to read to you the subtitle of the book and the little blurb. Overdosed America, the Broken Promise of American Medicine, How the Pharmaceutical Companies Are Corrupting Science, Misleading Doctors, and Threatening Your Health. Those are pretty strong words, but I think you will see that he amply documents those statements. The author, John Abramson, was a small-town family doctor in Massachusetts, just north of Boston, for 20 years. He was also involved in doing research and teaching. He studied research and statistics at several universities. He also taught a course at Harvard with Herbert Benson, a name many of you will know, on mind-body medical interactions and their importance in the doctor-patient relationship. He's clearly both a well-informed scientist and also a humanist who is strongly interested in the welfare of his patients, and that comes through strongly in the book. In the 1990s, he noted a growing waste and commercialism creeping into medicine, and it dismayed him how it was altering his interactions with his patients. And finally, he became so interested in this that in 2002 he left his practice to research and write this book. The book is divided into three parts: a family doctor's journey of discovery about the big changes that he sees in American medicine, the commercial excesses and so forth. Center part of the book documenting this commercialization, the influence of ads and education that come from the drug companies, which he calls conning doctors and the public. And then the third section, taking back our health, ways that we can protect ourselves from this drug culture that we live in. The changes that he saw in medical research are listed here. Before 1980, most medical studies were publicly funded, and most academic researchers scorned industry support. Now, 3/4 of clinical studies in the top 3 medical journals are industry funded, and many of the authors are academics who are supported by the drug companies. As a result of this, medical knowledge now grows primarily in the direction of drug company profits, not necessarily for patient benefits. And all of this leads to a bias in our culture. Industry-funded studies are 3 times as likely to support the use of a drug in a given situation as are other studies of the same drug that are not industry funded. Now, all these drugs would be would be fine if they had benefits without side effects, without costs, but the sad fact is that we now know at least 106,000 deaths per year, that's roughly 2,000 a week, in this country come from known adverse reactions to prescription drugs. And I'm not talking about drugs that were taken incorrectly or abusively or anything like this. This is recommended use, prescribed uses of the drugs. We also, many of you are aware, live in an era of rapidly rising drug prices. The drug companies blame this on their research costs, and that's partly true. It is very true that it is exceedingly expensive to develop a drug, get it through the FDA process, get it approved and out to the market. Hundreds of millions of dollars and years of time. But the interesting fact that they don't emphasize is that they are now spending much more money than they do on research for marketing those drugs. So the high prices that they charge for these drugs includes mostly money to help them promote the drugs and get you to use more of them. So the high prices are mainly to promote use rather than to develop the drugs. And then we have this startling quote, most drugs do not work for most patients. You'll never guess where I got this quote. I'll give you the answer in a few minutes. It would be fine if they worked well, they didn't cost much money, and they didn't have a lot of side effects, but unfortunately that's not true. Now, please, those of you who are less scientifically inclined, perhaps bear with me for this slide and the next one. I'm going to go into some of the details that he talks about early in his book under the heading, first of all, of spinning medical research. He talks about a study of Pravachol, that's a statin drug, pravastatin, that was published in the New England Journal of Medicine. And the headline of that study was that in patients who had already had a heart attack, there was a 19% reduction in the risk of stroke in those who took Pravachol compared to those who took a placebo. Now, this 19% is what we call a relative risk, and that sounds wonderful, but you can't just look at relative risk, you have to also look at absolute risks. That 19% was a drop from 4.5% down to 3.5% in a 3.7% in a 6-year study. That's where the 19% comes from. This works out to preventing about 1 stroke out of 1,000 patients taking the drug per year. And when you say it that way, it doesn't sound quite so impressive. And then when you figure in the cost of the drug, this works out to $1.2 million for each stroke that was prevented. And that's just including the price of the drug. It doesn't include the price of the ongoing tests that are required in people who are taking statin drugs, and it doesn't count side effects from the drug, which can be sometimes very serious and costly. Now, Abramson also dug further into this study, and he noticed that the average age of the subjects was 62, and that 83% of the subjects were male. And he said, wait a minute, they were studying the wrong subjects. The median age for strokes in the United States is 71 for males and 79 for females. And this is important because if you look carefully at the study, it turns out that the study subjects who were over 70 actually had a trend toward more strokes taking the drug rather than less. And furthermore, if you looked just at the women in the study, in whom 60% of all strokes occur, they had a trend toward more strokes also taking this drug. So he considered that publication of this study by New England Journal of Medicine was breaking faith with the doctors who use these kind of studies to guide their practice and who usually don't take the time to look beyond the headline that says 19% reduction of stroke risk. Now, spinning is one thing. It happens all the time. Unfortunately, there is also outright misrepresentation that occurs in our major medical journals. He talks about these two studies, two drugs, Celebrex and Vioxx. These are two blockbuster or formerly blockbuster pain relievers that were introduced about the year 2000, 2001. They were launched by these two studies. The first one, Celebrex, was launched by a report in JAMA, that's the Journal of the American Medical Association. It reported fewer gastrointestinal side effects after 6 months of using Celebrex compared to other non-steroidal anti-inflammatory drugs like aspirin and naproxen and so forth. Now, aspirin works, we know, in many people, but it has the unfortunate side effect that it causes bleeding and ulcers and sometimes very serious gastrointestinal side effects. The whole idea of Celebrex and Vioxx was that they were biochemically sophisticated so that they would not cause those side effects. That was the intended purpose of developing these two drugs. And so here we have this report coming out in JAMA that indeed says there were fewer gastrointestinal side effects. Unfortunately, this study was misleading, really misrepresenting what the drug company knew from their own data. They only reported the first 6 months of a study that they actually did for 12 months, and they didn't say that they had done it for 12 months. If you looked at the second 6 months, there were actually more gastrointestinal side effects. And these are drugs that people often take for many months or years, for arthritis, for example. It also turned out not to be true if they hadn't grouped together mild effects with serious effects. Now, the whole idea of these two drugs was to avoid the sometimes very serious effects that occur with aspirin and other non-steroidal anti-inflammatory drugs. If they had just reported the serious effects, it turns out that the intended purpose of this drug wasn't even fulfilled. The serious side effects, even in the first 6 months, were worse with Celebrex than with the other drug that they compared it with. But what they did this little sleight of hand of combining the mild effects with the serious effects and only reporting the sum total of those two, which is just outright misrepresentation. This drew warnings from the FDA and rebukes from the journal. The author of an editorial that came out with this article, see if I can find it here. He said, I am furious. I looked like a fool that he didn't know about. They didn't report the second 6 months of the study. The editor of the journal said, I am disheartened to hear that they had those data at the time they submitted the manuscript to us, and perhaps they broke a trust with us. She's being kind, I would say, to say perhaps. Now, similarly, about the same time, Vioxx was launched with a study in New England Journal of Medicine, and indeed, it did point to a lower risk of serious gastrointestinal side effects, but their own study showed that it had a 2.5-fold higher risk of other serious side effects, mainly affecting heart. And as many of you know, that ultimately was the downfall of Vioxx. It was taken off the market because it had caused approximately 100,000 serious events such as heart attacks and serious heart disease. Before it was taken off the market, though, it was on the market, I guess, a couple of years, it sold $7 billion worth of drugs based on this study that said that it was beneficial and did not report the data that they knew that it had more serious side effects than the other drugs that it was replacing. Okay, well, those are examples of where Abramson, the scientist, goes into the statistics and the details of the research and points out how the drug companies spin and mislead both doctors and the public into using their drugs. Now, I'd like to take a little survey here to help keep you awake. I've got 3 questions, if you'd show your hands. Would you take a drug every day for 5 years if it, A, lowered your chance of having a heart attack by 33%? Quite a few, okay. B, lowered your chance of having a heart attack from 3% to 2%? Nobody. Oh, I see one, okay. A lot less, though. C, saved 1 person in 100 from having a heart attack with no way of knowing who that 1 person will be. Any takers? There's one. There's one. Okay. Well, this is getting at that issue of relative risk versus absolute risk. And I'm going to come back to it again. But maybe some of you have guessed. A, B, and C all describe the same situation. They all describe a 5-year study of a drug to reduce blood pressure, that reduces blood pressure in order to reduce heart attacks. And indeed, there was a 33% reduction in heart attacks in the study group compared to the placebo taking this drug. And of course, guess what the headline from the drug company is going to be? It's going to be A. That's where a lot of people raise their hand. But you can't just look at the relative risk, this 33%. You also need to look at the absolute risk, which was 3% in the group that didn't take the drug and 2% in the group that did take the drug. And there is your 33% reduction, from 3% down to 2%. Okay, and another way of saying B is it saved 1 person in 100 from having a heart attack, and of course you don't know who that person's going to be. I'm taking this from some pharmacists at the University of British Columbia. They go around asking this survey to both doctors and lay people, and everybody is surprised by the results, including doctors. You get a lot more hands with A than you do with B and C, and of course that's why drug companies will always say A and not B or C. Now, drug company influences are widespread in our culture. Some of the obvious ones are here. 70% of continuing medical education that doctors are required to have in order to maintain their license is funded by drug companies. As I mentioned, most drug research now is funded by drug companies. The practice and treatment guidelines that come out of committees and panels that doctors use to help guide their practice, the panelists, nearly all of them have conflicts of interest. They are on the payroll of the drug companies when they make these recommendations for drug treatments. For example, the 2001 cholesterol guidelines that have a lot of people on statin drugs, 90% of the panelists had connections to the drug companies that make these drugs. Another obvious influence of these companies is their public relations and advertising, which try to make every problem into a medical problem that they have a product to treat. An ever-expanding list of conditions where lifetime treatment with drugs is advised, including things like shyness, which they have renamed social anxiety disorder, and menopause, which is turned into a disease, supposedly a disease due to hormone deficiency. And you all know the debacle of treating that with hormone replacement therapy. That's a separate chapter in his book. It's very interesting. Then there is direct advertising to consumers. You see all kinds of ads on TV, radio, many full-page ads, multiple-page ads in magazines. The reason we see all of these is because they work. They get people interested in drugs. And Abramson talked about the pressure that he felt in his practice. The patients who would come in, they've been reading these ads or seeing these ads, and they say, hey, I've got tennis elbow and I want Celebrex. You know, the ads had that effect. The effect was so strong that 1 year after those two studies came out that I mentioned, 57% of the money being spent on arthritis prescriptions was spent on those two drugs that had just been introduced 1 year before, Celebrex and Vioxx. A lot of people would be turned off by the huge cost of these drugs. They cost maybe 5 or 10 times as much as the competing drugs, that they're really no better than, and have more side effects, but they cost this huge amounts. But very often people don't care because they say, oh well, my insurance will cover most of it. And the result of that is that these costs get passed to the public in general through our employers who have less money to pay a salary because of the very high cost of paying for the health insurance. Now, Abramson talks about how he tried to tell this person with tennis elbow and others who would come in that these drugs were really no better than other drugs. And in the case of the guy with the tennis elbow, he really didn't need a drug so much as he needed to modify the way he was playing tennis, maybe get a racket with a little bit looser strings, modify his swing, and so forth, instead of treating the symptoms with a painkiller. But very often that was not very successful, and he felt that this often interfered with the relationship that he had with his patient. He either had to go along with the patient, which he often did because he was very kind-hearted, really, or he had to risk turning them off, being uncooperative, quote unquote, and saying, no, I'm not going to prescribe this. It's not really the best thing for you. He feels that it strongly interfered with his doctor-patient relationship. We spend 15% of our gross domestic product on health care. That's figures from 3 years ago. Highest in the world, much higher than other countries such as 8% in Japan, England, New Zealand, and Spain. Now, that's 1 out of every $7 that we collectively make goes into health care. Now, this would be fine if we were getting really excellent health as a result. And Abramson said, I assumed that we were. I assume, and many people do, they assume that we have the best health care in the world, the best health outcomes in the world, but that turns out to be not true at all. He couldn't believe the data when he found it at first, but he kept finding contrary data and sadly came to the conclusion that we are very far from the top in what we get for our medical care dollars. Our life expectancy at birth is the lowest of the 12 most developed nations, 78 years. Japan is 83, Italy 81, Australia and Canada 81. Our infant mortality is the highest of these 12 countries, 0.6%, double what it is in Japan, Norway and Sweden, for example. This is one data that he found. Another is shown in this graph. This shows not life expectancy, but healthy life expectancy, which is adjusted for the quality of life. It's a measure that's published by the World Health Organization. And this healthy life expectancy, which is a little shorter than total life expectancy, is plotted here against the amount of money that is spent in these countries on health care. And remember that many of these other countries have universal health care, whereas we do not. Japan, Sweden, and Switzerland are examples of countries with very high healthy life expectancy and low or medium spending on health care. The Czech Republic, relatively low healthy life expectancy and very low spending. The United States really stands out as a country that is spending a lot and is not getting results that are comparable to these other developed countries that are plotted here. This was another of the things that he found hard to believe when he first ran across these data. Now, here's the answer to that question. Where did I get that quote, "Most drugs do not work"? The surprising answer is a senior executive with Britain's biggest drugs company has admitted that most prescription medicines do not work on most people who take them. This was Alan Roses, who happens to be a professor of genetics at Duke University. He's the worldwide vice president of genetics at GlaxoSmithKline, Britain's biggest drug company. He said that fewer than half of the patients prescribed some of the most expensive drugs actually derived any benefit from them. Remember, when a drug study shows that there's an overall benefit to the group, to the study group, that doesn't mean that everybody benefited. It just means that probably more benefited than didn't. You never have a drug that's effective for everybody. The article, this is from a British newspaper, it said that it's an open secret within the drugs industry that most of its products are ineffective in most patients, but this is the first time that such a senior drug boss has gone public. Now, more on drug company influences. There are some subtle influences that they exert, not directly through advertising or continuing medical education, but through public relations firms that put out news stories that don't always obviously have a connection to the drug companies, or they may fund nonprofit groups that put out things. And they disguise their support of them by passing the money through a nonprofit group. One of the examples of the subtle influences through public relations firms that you've probably heard in the last few years is lots of worries being raised about people who go to Canada to get their drugs. And you've seen these stories about, they may be selling counterfeit drugs. They may not be the real thing. Okay? Well, these stories were planted by the drug companies through their public relations firms, and one of the firms got an award for the best public relations campaign for this thing. And the fact is, at least at that time, there had never been one example documented of a counterfeit drug being sold by a Canadian pharmacy. It was just a big scare story that had been cooked up by the publicity. Now, drug companies also dominate medical reporting, both to physicians and the public. You see stories in the newspaper that may not identify drug companies being the source of this information, but it really is. We're always hearing about these new drug breakthroughs that we should talk to our doctor about, and that's what Abramson often doesn't like, remember? And this culture has convinced us that drugs are the answer to practically every problem. So the result is that we have a lot more focus on using drugs to counter our problems than on alternatives, which may be more effective, less expensive, and less dangerous. Toward the back of the book, Abramson talks about this neglect. And he has a section on these 7 diseases: osteoporosis, coronary heart disease, stroke, and so on. I'm going to go into a little bit of detail of what he has to say about the first one, osteoporosis. I don't have time to do the others, but it'll give you a flavor of the sort of thing that he puts forth about how important this neglect is. First of all, he says osteoporosis was very little known until the drug companies launched an education program in 1982, and it really took off in 1993 when the World Health Organization issued new definitions of what osteoporosis is. Before, osteoporosis was only diagnosed after someone had broken a bone due to the bone being weak. The new definitions defined osteoporosis as someone having a bone whose testing of bone mineral density showed that the density was significantly less than the density of a young woman, the natural density of a young woman. And when you compare women age 72 with young women, half of them, by that definition, have osteoporosis by the age of 72. And this WHO organization advised bone mineral density testing, despite there never having been any randomized controlled trials showing that it had value, ultimately, that if you tested one group and compared it with another group you didn't test, that it really had a benefit. And not told was that this study by WHO had been funded by 3 drug companies that were about to have osteoporosis drugs coming out in the next year or 2. So this was a very deliberate campaign to get people interested in getting bone mineral density testing and then taking these drugs if it turned out that they were in the half of the women age 72 or more who would test low on this bone mineral density test. Fosamax was the first of these drugs, introduced in 1995, initially it was based on studies of women who had osteoporosis in the sense that they had already broken a bone. And they did a study, there were several of them, this is one of them, a 1998 JAMA, Journal American Medical Association study, that found a 56% reduction in repeat hip fractures in women who had low bone mineral density. Now remember, this 56%, that's the relative risk. But you can't just go by relative risk, you have to look into absolute risk. The absolute risk reduction was only 0.3% per year. In other words, the chance per year of having a fracture dropped from, say, 0.5% down to 0.2%. That's the 0.3% reduction. So the absolute reduction doesn't sound so impressive as that 56%. It turns out that this requires that you treat 81 women for 4.2 years to prevent 1 hip fracture, and the cost of the drug is over $300,000 to do this. Those are the kind, the drug companies emphasize line 1 and they don't emphasize the later lines. And unfortunately, it turns out that bone mineral density testing does not do the job very well. It predicts only about 1/6 of the risk for breaking a bone for women age 60 to 80. Much stronger predictors are frailty, weakness, side effects of other drugs, for example, that decrease balance, smoking, things like that. And so the bottom line is that bone mineral density testing is a poor predictor of fracture risk, but a very good predictor of drug use. What about using these drugs to prevent a first fracture in women? That was also studied, and the FDA approved Fosamax and one of its cousins, Actonel, for women who had mild bone thinning. They didn't have osteoporosis, even by this new definition, but they did have a trend in that direction, some mild bone thinning. It's called osteopenia because of because of increased, I should have said decreased bone mineral density. But it turns out, unfortunately, that the drugs given to these women do not reduce fracture rate. Oh, I'm sorry, my notes were not wrong. The reason that the FDA approved Fosamax for this purpose was because they did increase bone mineral density in these women. Okay? But this is what you call a surrogate outcome. Bone mineral density went up, but does that mean that fracture risk goes down? It turns out that the answer is no. The drugs do not reduce fracture rate. How can this be? More dense bone, but no improvement in fracture rate. Well, it turns out that the situation is more complicated than you might think. There are two kinds of bone. There's the outer bone that you see in the bones in the meat that you buy. It's called the cortical bone, represents about 80% of the weight of our skeletal bone. Then there's this inner bone, which is not everywhere, but in some bones where strength is really needed, a mesh-like web in the center of the bone that's called trabecular bone. And that is really important for the strength of bone. And it turns out that the drugs build mainly outer bone and not this trabecular bone, which is what gives it the strength. So here we have a drug that's been approved for the purpose of preventing a first fracture in women who have low mineral bone density, and the drugs do improve the bone density, but they do not decrease fracture risk. Now there's another drug, Evista. It's a new type. It is intended to mimic the effects of estrogen, which women lose at menopause, and it's intended to do this without the risks of estrogen. And the ads, it's been approved based on the fact that it has been shown to reduce the risk of spinal fractures. But those are fairly uncommon and not deadly the way hip fractures can be. Hip fractures and wrist fractures are the most common and the most debilitating to people. And Evista does not do that, although the original ads for Evista implied that they did and drew a rebuke from the FDA, a warning letter to them to stop implying in their ads that Evista had these effects on hip fractures and wrist fractures. Now, moving on to the part of the book where he talks about better and cheaper ways in the case of osteoporosis. First of all, we believe that it is important during youth to have a good diet and exercise in order to encourage building strong, dense bones during youth and early adulthood. It is apparently normal for women and men too to lose bone density as they get older, but if you start out with a higher density to begin with, then you can afford to lose some without the bones becoming too weak. Now, moving on to older women, in this case, there was an NIH-funded 7-year study of about 10,000 independently living women, 65 years old and up. It found a 36% fewer rate of hip fractures in those who exercised moderately compared to the women who exercised the least. And in this case, that's, again, a relative risk, and you should be asking in your mind, well, what about the absolute risk reduction? And the answer to that is the absolute risk reduction was 6 fewer fractures per 1,000 women per year. And that is twice as great as the absolute risk reduction of the Fosamax study that I mentioned to you at the beginning. That cost, what was it, $1.2 million to prevent 1 hip fracture. Here you have something that we all should be doing anyway, exercise, free, twice as great a benefit as Fosamax. Then there was a study in Sweden, a fall prevention program in a nursing home where about 1/3 of the subjects had dementia. The average age was 83. The interventions, see if I've got that in my notes here. Well, I don't find it immediately, but the interventions were things like reviewing the drugs that they were taking and trying to eliminate any that might contribute to dizziness or a loss of balance. They also used hip protectors on some of the elderly women. They also had whenever there was a fall at the nursing home, they would have a panel meeting to discuss how they could prevent a recurrence of the fall. Things like that. The intervention was strikingly successful. During the 8-month study where they were doing the intervention, they had only 1.6% rate of hip fractures compared to a 6% rate in the control group. And if you convert that into per 1,000, like we've been talking about, that's 16 per 1,000 versus 60 per 1,000 per year. This is a huge absolute rate of risk reduction. Far, far, far more effective than any drug, and of course much cheaper. But the drug companies, of course, don't tell you about this part. Now, osteoporosis is a complicated thing. There are many other things that we can do. Diet and supplements. Everyone's heard about calcium and vitamin D. Not so many people are aware that there's a lot more involved than just those nutrients. Magnesium, potassium, and vitamin K, for example, are all involved. Basically, good diet, whole foods, not eating a lot of sugar and other refined foods is the way to protect our bone health. Another thing that can be done is strength training. Believe it or not, 80, 90, 95-year-old people in nursing homes, strength training helps not only to improve their bone strength, but it also improves balance, which is an important thing in reducing falls. If you want to read more about that, there's some books by Miriam Nelson at Tufts University. Strong Women Stay Young is the title of one. I gave a talk about that several years ago. She has some other books out, too. Weight training for elderly people can be very beneficial. Another thing we're learning is that Tai Chi, a Chinese exercise, improves balance and reduces risk. Unfortunately, there are no corporate sponsors of heavy advertising for these kinds of interventions, and the result is that we have a disproportionate idea in our mind that, gee, drugs might be a good way to go as opposed to these other ways. Now, just summarizing, as I said, I don't have time to go into all the other things in his book, but for the other conditions that he talks about, I've put in short one-liners here about things that can be done to improve these various disease conditions. You'll notice that exercise, diet, body weight is prominent in most all of these. Smoking, in the case of heart disease, shows up. I mentioned sugared soft drinks for obesity. There's good research indicating that at least in children, consuming sugared soft drinks tends to increase obesity in children. These are the things that we're not doing enough of because all of the emphasis on drug approaches to these various conditions. What doctors can do: stop seeing drug company representatives. He says this is not anti-drug, it's not anti-drug company. It is trying to not be unduly influenced by the drug companies in order to make better decisions. He says the drugs are essential, but the overemphasis, the overselling, and the spinning and the misrepresentation of drugs, that is not helpful. Doctors can stop attending company-sponsored continuing medical education. They can stop accepting gifts from drug companies. I personally know of an allergy office in Austin where pizza lunches and little kitchen timers with drug names on them, and of course notepads and ballpoint pens and all kinds of things with the drug company. AMA ethics guidelines say that doctors should not accept any gift that does not directly benefit patients. But that guideline is routinely not followed by accepting things like lunches and these little gifts. Some people would go so far as to say doctors should not accept free samples of drugs to give to their patients either. Now that doesn't fall under the guideline because that is directly for the benefit of patients. But that is a questionable practice, whether doctors should accept free samples to give to their patients. Stop accepting money to speak or write on behalf of drug companies. Many articles that doctors write extolling the use of some drug, they may not identify that they were paid by a drug company to write this article. What the public can do: be aware that drug ads can be misleading. I would say probably usually are misleading. Be aware that their research and reports are usually slanted and sometimes rigged. Remember, their first goal is their profit, not your benefit. Remember that there are often, maybe usually, better and cheaper solutions that aren't widely advertised. And finally, it occurs to me that just say no might be something worth keeping in mind. You know, that's the phrase for illegal drugs, but maybe we ought to think about it for the legal ones too. Remember individual differences. My mentor at the University of Texas, Roger Williams, wrote books about biochemical individuality. Everyone is biochemically different. No drug is effective for everyone. No drug is safe for everyone. Unusual adverse reactions are rarely found until a drug has been on the market for a few years. And this is one reason that many people say, don't even think about taking a new drug. Wait till it's been on the market for a few years. And finally, pay close attention to any reactions that you may have, and don't assume that they're not caused by a drug that you're taking. Public policy ideas, Abramson's ideas, a new independent medical board that would reorient medical research toward health and not toward profit, to oversee clinical guidelines to include non-drug alternatives, require comparison of old and new treatments. That's something that's very sadly lacking right now. The FDA, to approve a drug, the company only has to show that the drug is better than a placebo. It doesn't have to show that it's better than an older, cheaper drug. That's something that we really need to do. A national clinical trials registry so that drug companies can't do trials that have negative results and not tell the world about them. And to require full disclosure of research data. Here's an example that Abramson gives. When the manufacturer of Paxil performs 9 clinical studies on the treatment of adolescents for depression and finds it is no more effective than placebo and in fact significantly increases the risk of emotional lability, including suicidal thoughts and attempts, it's no problem. The company publishes one study that shows a benefit, fails to publish the other 8, and markets away. When British drug authorities spill the beans, no problem. An American task force is assembled and finds that it's safe. Too bad, he says, the task force didn't have the full information that the British experts had, and furthermore, 9 out of 10 of the members of that task force had industry ties. These are the kinds of abuses that some of those public policy changes could help to prevent. And finally, quickly, I'm running out of time, but I want to show you 3 places for further information. If these ideas intrigue you, here's where you can go to get more information. They're all 3 recommended by Abramson. This Therapeutics Initiative, number 1, he says this is the best site for complete, unbiased scientific evidence about commonly used drugs. It comes out of the University of British Columbia. It's oriented toward both doctors and patients. It gives brief, practical, referenced, and reviewed reviews. They've published 62 of these therapeutics letters, they call them, since 1994. I've listed the titles of 3 of them here to give you an example of the sort of thing that they put out. A second source of information, this one is oriented toward medical consumers. They've been publishing evidence-based guidelines since 1976. They focus on drug safety and the effectiveness of drugs and advertising, evaluation of medical and surgical treatments, medical tests, and hospital safety. There's a website here. On that website, if you click on the articles link, there are over 70 free articles that you can get. I'm not going to spend time on it, but my next slide, which you have in your notes, lists the titles of a whole lot of those 70 articles. They publish a Health Facts newsletter. It comes out once a month. It's $25 a year, and I've been a subscriber for many years, and that's the reason I'm here giving this talk, is because in 2004 they had a review of Abramson's book, and I was really intrigued by it, and I passed this information on to the doctors here at the center, and here I am giving this talk. And then the last source that I want to mention is that's recommended by Abramson. It's called Worst Pills. They published the book Worst Pills, Best Pills. They have a website. They have a list of 211 drugs. In my notes it's 185. It's now today up to 211 that you should not use. You can search by drug, disease, and so forth. This is not in your notes, but this is some of the drugs that are on their list of drugs not to take. For each one, they tell you why and what alternative they suggest. And then finally, if you want to read more books, these are 3 other books with similar themes. The first one, by the way, is by the former editor of the New England Journal of Medicine. She quit the journal because she was so upset by the changes that have occurred in medical publishing and research. So thank you very much for your attention. I hope this has been interesting. Thank you.
We do have time for just a couple of questions. We have mics walking around, so if you wait for the mic.
Okay. Yes, I'd like to know, I just had a doctor recently tell me I'm on Lortab, like 7.5 for knee problems. I was told that I needed to get off the drug because the drug could actually be causing the severe pain that I still have in my knee. Have you heard that before, or do you think?
No, but I certainly could believe it. Those kinds of things happen all the time. Yeah, I'm not a physician. I'm a nutritionist. in research. So I'm not familiar with that kind of drug, but I read a lot of these kind of studies, and that kind of thing happens all the time.
Can you go back to that list, just the previous one back?
Thank you.
You said that WHO had studied osteoporosis and did studies that were funded by drug companies. I think that's the World Health Organization that's part of the UN, who I would have thought was above compromise. You think they may have been duped some?
Yes, yes. I don't always assume that industry funding leads to wrong conclusions. That's not necessarily true, but it often happens. And the WHO recommendations on bone mineral density testing, that was strongly influenced, obviously. It was paid for by the drug companies, and it turns out that bone mineral density testing hadn't been studied, and when it is studied, it turns out it really doesn't help.
There is a national initiative called Just Say No, that's spelled K-N-O-W. Before you take a new, before you take a new drug, find out about it. Look it up on the internet, look it up in a PDR, but be a knowing consumer rather than just assuming that it's going to be okay.
Great.
Just say no.
Is that an organization that...
Yeah, I can't remember who it is, Don.
Okay. If you did a Google, Dr. Iran says there's this organization, Just Say No, spelled K-N-O-W. If you do a Google search for that on the web, you'd probably find it. Yeah, that's great.
We'll take one more question.
Yes, I'm trying to understand more clearly how the drug companies, when they put out their research, how they get from the, say, the 19% reduction in risk versus the absolute risk. How is it, again, that they manipulate the numbers to get to that?
Okay, well, say there was, I think the numbers were something like 4.7% of the study group had a fracture, or no, 4.7% of the placebo group had a fracture, and 3-point-something% of the study group getting the drug had a fracture. And the difference between those two numbers is 19%. Okay? Whatever those numbers were. I didn't check it, but the difference is supposed to be 19%.
Okay.
And the 19% sounds a lot more impressive than reducing risk from 4-point-something to 3-point-something.
Is that because the group of people was so large that they...
No, it's just because that the risk to begin with is fairly small. So you can have a 19% reduction of a small risk, and the net benefit is not that great. And you have to give the drug to a lot of people for a long time and spend a lot of money in order to get one less hip fracture, which is what you're really caring about.
Okay, thank you.
Thanks for that question, because I suspect that other people have the same question.
The preceding program was presented by the Center for the Improvement of Human Functioning International in the Bright Spot for Health Lunch and Lecture Series. To inquire about additional health-related information available on DVD, audio CD, VHS, or audio cassette, simply call 316-682-3100 or drop by 3100 North Hillside in Wichita, Kansas. To discover more about the Center and what we have to offer, be sure and visit us on the web at www.brightspot.org.